Him. I'm an assistant professor at Boston University School of Medicine, and I'm a physician at Boston Healthcare for the Homeless Program. I'll be talking about mobile addiction treatment units. Now, um, what I wanted to do first, though, is I realized I don't have a slide for this, but I wanted to tell you a little bit about myself because, to my knowledge, all of you are medical students. Is that right? More or less. Okay, so basically, just to give you a sense of my path here, but basically, I'm currently assistant professor at BU. Half my time is seeing patients in shelter-based clinics through Boston Healthcare for the Homeless Program. And the other half of my time, I do research on addiction and homelessness, some of which I'm going to be talking about today. But I grew up in Raleigh, North Carolina. I went to undergrad at Harvard. I did Teacher America for 2 years at a high school in Newark, New Jersey, which was very fun, and I enjoyed that experience a lot. And it taught me a lot about injustice and inequity in the U.S. But after that, I went to medical school at UNC Chapel Hill. I was very active in the free clinics there, both a rural one and then the urban one in Carver, North Carolina. But after that, I went to Yale for residency for a combined internal medicine and pediatrics program. The program there, Yale has a very strong addiction medicine program, and even as part of my family medicine clinic, we were doing buprenorphine prescription, which was really cool back then, especially. And then even when I was a resident, I was active in the free clinic at that the Yale students ran as an attending. And I really had wanted to work with an underserved population in my career, but I hadn't specifically worked with people experiencing homelessness like you all. It sounds like you're very active in street medicine. Um, but I ended up doing a research fellowship because what I wanted to do was figure out ways to change policies that would be more supportive of people who were marginalized by the current healthcare system. While I was in residency, Obamacare or the Affordable Care Act passed, which expanded healthcare to many, many millions of people. And it was interesting to see how powerful policy work could be. So I did this Gen Med fellowship at Harvard. And as part of that, we were allowed to do half a day a week in a clinic somewhere. So I emailed around Boston and I'd heard good things about healthcare for the homeless. I emailed them and they were looking for a part-time provider. And I started doing shelter-based clinical work. At that time, that was back in 2013, and I fell in love with it. So actually, after the 2-year research fellowship, instead of doing research mostly, I actually did clinical work full time at Healthcare for the Homeless. I spent half my time on the adult side, including in medical respite, and then half my time on the family team, seeing adults and kids in family shelters, doing a lot of addiction medicine throughout. I ended up getting addiction medicine board certified within my first couple of years of my job. And then in 2019, I got recruited to be faculty at BU and to have half my time be research. A big part of my research portfolio was on what's called the Healing Community Study. The Healing Community Study, for those of you who are at all, if you're in Massachusetts, New York, Kentucky, or Ohio, you might have heard of it, but it's the biggest ever NIH funded um, addiction medicine study. And it was meant to be community engaged. So we picked 64 communities across the 4 states. And the way that it worked is that the communities each got to pick, they got a pot of money and they got to pick how to spend the money with the goal of preventing overdoses. So they could pick harm reduction interventions or medication for opioid use disorder or MOUD interventions that we knew were effective, at least research-wise, and they got to implement them, and then we studied that. So that's the sort of bigger context of the study. And this, I'm going to talk a little bit, I'm going to give some background and stuff, but basically, I'm going to talk about a study that we did within HCS, which is we interviewed the 5 organizations or communities that did mobile MOUD interventions to talk to them about their experience and successes and lessons learned and barriers and so forth. Okay. Oops. So, you all may have already seen this data, maybe even the specific paper, but uh, you know, about now 15 years ago or somewhere, like 12 years ago, it was being clear in a place like Boston, and this is true actually nationwide now as well, that overdose was clearly becoming a leading cause of death. In this study from 2013, I believe, yes, it showed that in a cohort of 28,000 adults that had been seen at healthcare for the homeless, overdose was the leading cause of death, and opioids are implicated in a majority of those. And what was actually a major lesson from this study was not only that overdose was the leading cause of death, but that it had actually replaced um, the most common causes of death from a decade ago, which were actually things like tuberculosis, pneumonia, HIV, even. And those death rates had gone way down, but overdose death rates had gone up so much that any progress we had made with those other diseases was eclipsed, and overall mortality rates had stayed the same. But overdose was clearly a big problem in our population. But one thing we do know, this diagram is from the American Society of Addiction Medicine, but it's the continuum of care for addiction treatment. So for those of you who are knowledgeable about this at all, there's basically like detox, you know, acute residential, longer term residential, halfway houses, sober homes, community based, and people with addiction can be anywhere, can need to be anywhere on that spectrum. But there are a few things that, regardless of where they are on that spectrum of intensity, that continuum of care, um, there are a few things that they need at all levels, all stages of that. Medications for opioid use disorder is an important one, and when I say that, I typically mean buprenorphine or methadone. Vivitrol or injectable naltrexone is also one as well, but typically not as effective. And we'll talk, I think, a little bit about that too. Yes, here. Um, so ASAM recommends that people have access to medications for opioid use disorder throughout this continuum. What's important to know, there are many important things, but this slide is actually a really great slide that I like a lot and I share a lot, and you all should take a few minutes to look at. But basically, the reason we know that medications for opioid use disorder are so important, partially is because of this really great study that a colleague of mine did at BU. But basically, he looked at about 18,000 people who had survived a non-fatal overdose. So these are people who overdosed, someone saved their life, maybe a friend, maybe the ambulance, maybe in the hospital, but they ended up in an ambulance or hospital. 18,000 people. Now, if someone almost dies of an overdose, right? Their chances of dying of an overdose at a future date are extremely high. You couldn't pick a higher risk group of people for opioid overdose death. But these are people who survived. If you followed them for 12 months, only 3 out of 10 of them got medications for opioid use disorder. Now, why is that important to look at? Because people who got medications for opioid use disorder were significantly less likely to die. Oops, sorry. Let me go back. You can't still see the screen, huh?
Oh, we can see it.
Oh, you can. Okay.
Yeah.
Okay. Okay. So people were significantly, if you look at the right, were significantly less likely to die. In fact, people of those 18,000 people, people that were put on methadone were 53% less likely to die. Now, you all are in probably your basic science classes, your clinical classes, and you'll look at the effect of certain medications and you'll see, you'll learn about things like numbers needed to treat and how many people you have to give the medicine to improve an outcome or potentially save a life. So methadone 53% is a number needed to treat to prevent death of two, right? That's exceedingly rare. I charge you to find another medication that is as powerfully effective as that at decreasing mortality. Um, and buprenorphine was not far behind with a decreased mortality rate of 37%. In this sample, very few people were on naltrexone. I think again because it doesn't honestly work that well, if we're honest. But there are various reasons that people want to try it, but there wasn't much of a difference. That said, the dramatic improvement in death chances of dying on methadone and buprenorphine is truly impressive. And what's also impressive that despite the fact that they're so beneficial, only 3 out of 10 in these 18,000 people got them in 12 months of follow-up. Okay. And the truth is, this is actually even worse for people who are experiencing homelessness. So this is a study that a student of mine did. There's a lot of numbers, but I just want to sort of break it down. The overall goal of this study was to look at differences in rates of inclusion of medications for opioid use disorder, or MOUD, um, among people who are housed and people experiencing homelessness, and how that changed after after expansion of Medicaid under Obamacare. But the key here is that in states that expanded Medicaid, which is now most states, um, if you were homeless, you had a 26% chance of MOUD being part of your treatment plan. If you were housed, it was 45%. So almost a 50% difference in MOUD inclusion based on homeless status. So you're basically half as likely. What's a little bit terrifying is that so almost 50% of people in expansion states who are housed get MOUD, but a quarter of homeless folks in expansion states get MOUD. If you're in a non-expansion state, it's pretty terrifyingly much lower than that. So some of you may be from states that don't include that haven't expanded Medicaid, but in non-expansion states, if you're homeless, you only have a 10% chance of having MOUD on your treatment plan versus only 15% um, if you're housed, both of which are very, very low, which is wild and unfortunate. But all that to say, is it on here? Okay, yeah. I think a lot of people will, when you're in clinical practice, and you may have seen these patients even as students, people may decline to go on to buprenorphine or methadone, and they have a lot of reasons, often many which are very, very strong, valid reasons. But what we ignore sometimes is the structural factors or the policy factors that keep people off. A state expanding Medicaid could dramatically expand access to MAUD, and many, many more people would have access to it, regardless of what, individuals, might be talking about in an exam room. Um, but one key highlight I wanna talk about is okay. So I think there's this eco-social model, which basically is like, okay, whenever you see a public health issue or problem, always think about the like expanding circles of influences on the person that's making that decision or having that outcome. So that might include individual factors, interpersonal factors, institutional factors, or policy factors. So that's going from the person and zooming out. And this same student actually did a study, a qualitative study, interviewing people with MOUD in several shelters in the Boston area, and asked them about decisions to start MOUD or not, and to try to figure out why. And one thing, the title of the study is Sick and Tired of Being Sick and Tired. But basically, a major lesson that came from this paper, for me at least, was that a lot of people said, I think from the medical perspective, there is this sense of, okay, we really need to start people, when they have a non-fatal overdose and we've revived them and they're in the ambulance or they're in the ED, which can be very effective. There's good data on that. But what people were telling us is that actually, after they'd received Narcan, was the last thing. After they'd received Narcan and been resuscitated, the last thing on their mind was MOUD. They were feeling so sick, they didn't want to talk to anyone about anything. They just wanted to, feel normal again and get back onto drugs. So, what they did say though is that there were times, in their day-to-day lives when they were sick and tired of being sick and tired, when they were open to the message of MOUD. And so they wanted interventions that met them where they were at rather than waiting for them to go to a clinic or a hospital. Um, and so that's what Healthcare for the Homeless did, is we built in partnership with a foundation, we built our community care and reach van. And this is a slide from the website about the van. But basically, the city had approached us and said, okay, we're seeing clusters of overdoses in neighborhoods that don't have addiction medicine clinics, healthcare facilities, hospitals. And so we know these are hotspots, but we don't know how to get them treatment. And so Healthcare for the Homeless, in coordination with a lot of other agencies, came up with this idea for a van, basically, a mobile addiction treatment unit, where MOUD, in this case, buprenorphine, would be available in a very low barrier way. And we would bring it to people who are sick and tired of being sick and tired, and were open to treatment with medications. As you can see, as of I think 2018 or so when this started, 2019 maybe, they've had almost 19,000 contacts with people, distributed 5,000 naloxone kits, and have had 2,500 clinical encounters, most of which were for buprenorphine. Okay, so that said, Healthcare for the Homeless. And so, both having been a provider on mobile units and as a researcher, I knew that we needed to learn, about them. So we did this qualitative study of mobile units that, as I'd mentioned before, were part of what's called the Healing Community Study. Again, Healing Community Study, 64 communities in 4 states. The communities get to choose what they want to do with the money to try to prevent overdoses, and um, at least five of them that just five of the 64 um, implemented mobile units and were willing to talk to us about them. So we talked about this. Medications for opioid disorder are life-saving, but most eligible patients never receive them. Traditional brick and mortar addiction infrastructure may not allow access for marginalized individuals, but mobile addiction treatment units or vans, vehicles, or portable clinics that provide low threshold, low barrier community-based services for addiction treatment, including opioid agonist medications like bupropion, could be an effective intervention for that. And then, as I said, as part of the Healing Community Study, five MATUs were set up across 2 states. We sought to understand their characteristics, the facilitators and barriers to their implementation, and then their future aspirations. We did semi-structured interviews applying the socio-ecological model, and we had 11 mobile MOU program staff from 5 programs in 2 states were interviewed. Okay, so the results come in a few buckets. The first bucket is physical space. So basically, they had a lot of tips and thoughts on the physical space. You needed storage space, you needed space to see patients, you needed lockable cabinets, you needed wireless internet, you needed chargers for electronic devices. Potentially, depending on what you were doing, you may need restrooms for urine tests. And this actually becomes important later because a lot of this stuff was very challenging for regulators, like state regulatory agencies, to like wrap their minds around. And so, whether or not and the extent to which you need a restroom for urine tests may be partially related to the regulations around mobile units in your state. And then phlebotomy chair, I think, is important because a lot of places wanted to do HIV, a Hep C testing, that sort of thing. So some of the quotes from our participants. So I went and looked at the van and drew up some plans to re-outfit it. So the back should be more comfortable. It should have more storage room, like locking file cabinets, things like that. And another participant said then it was a lot of learning curves around purchasing the van, what we wanted the van to look like. I already had an idea of how we wanted to have a phlebotomy chair in there, how we wanted to have the shelves set up, how we could do testing, how could we have lights. Okay, so that's a physical space. People describe the services they provided, so everything from harm reduction, including naloxone, fentanyl, test strips, smoking supplies, nursing services, insurance enrollment, which ended up being very, very important. Snacks, clothes, sleeping bags, transportation support, HIV, Hep C, and STI testing and treatment, post-overdose outreach and recovery coaching. As someone says, I mean, sometimes it's not just MOUD. I remember this one time I got 5 financial counseling appointments. They wanted insurance and also PrEP to prevent HIV infection, Hep C treatment. That they're there reliably with snacks, supplies, whatever else is something that people have really enjoyed. So often things like giving people snacks or supplies, getting them signed up for insurance were things that brought people in, and then we could talk about addiction stuff after that. And then fentanyl test strips were a really big hit too, which is actually really cool. Okay. And then facilitators for a successful rollout of mobile units, so personal and organizational values. So it's much less stigmatizing. It speaks to why we just have so many patients in treatment right now. Um, so basically, organizations that did this well consistently talked about wanting to meet people where they were, trying to destigmatize addiction treatment, and having those values was crucial. And honestly, in retrospect, having worked with healing community study, there are a lot of organizations out there, healthcare organizations that don't have those values. They don't have the value of wanting to meet people that where they are or wanting to destigmatize substance use treatment. They don't have those aren't their values, and so they wouldn't be able to do this well. Secondly, community relationships. So everyone was just working together. I don't know, everyone was just on board, and it's great. So again, agencies that operated mobile units, it was crucial that they had good relationships with other organizations in the area. So, it might be the methadone program, the syringe services program, the community health center, a pharmacy, right? Because if you're prescribing buprenorphine, you need a pharmacy that's reliably going to be able to take the scripts and help troubleshoot and make sure patients can get that medication. Now, just incidentally, this will come up later, so we'll talk about it later. Okay. And then another facilitator was federally funded study participation. They were like, you've got a question, we've got people to answer that. So on one level, I think Healing Community Study being able to provide funding support for these mobile units was really helpful. But the other thing that Healing Study did really well is that we provided what's called training and technical assistance. So if any of you knows Massachusetts, so we're based out of Boston. We had already in Boston rolled out these mobile units, but someone in Brockton, right, wants to roll out a mobile unit to be able to get training and technical assistance from us in Boston to troubleshoot, any issues around this was really helpful. And actually, one of the cool things that Healthcare for the Homeless did after they rolled out their community care and reach van is to make a like an online open available sort of pamphlet FAQ implementation guide for mobile units, which I think is really helpful. Okay. So barriers, one major barrier is, okay, so intra-agency concerns. So staffing. So part of the thing with healing with the mobile units in this study was that some of it was implemented during COVID. And in the COVID and immediate post-COVID period, staffing was a huge issue. There's a lot of, people leaving healthcare, a lot of people burning out and leaving. So this person said, so I was supposed to be on the van, but that happened quite a bit where I was needed to do other things. So people would be pulled from the van and have to do other things. And the problem with that is that these vans often require multiple people in order to be able to run, including like a driver and the person to do the visit. So the next thing that was actually a crucial thing was financial sustainability. So I can't do 16 visits on a van that doesn't have a lobby or have anywhere in the winter for people to sit outdoors or wait. And so the like financial expectations around how many visits you do that are reimbursable and my Medicaid was an issue. And of course, when you're not making enough money from your visits and Medicaid reimbursement, insurance reimbursement, you have to rely on grants. And for example, our grant was a 5-year grant. So obviously that funding was going to go away. A lot of grants go away in its time period. So that was always on people's minds. Okay. So clinical and regulatory barriers. Actually, let me just make sure. Okay. Oh, yeah. Clinical and regulatory barriers. So the way that the licensing regulations are right now for mobile programs, they weren't designed for the type of programs that are mobile. This became a huge issue for several of the programs. So Department of Public Health in Massachusetts, and this is probably going to be true in any state, some version of that has to regulate anything that calls itself a clinic, anywhere that you're going to be prescribed medications. And for one program in particular, working with DPH, which had never licensed a program like this in a community like that, was extremely challenging, and it resulted in lots of delays. And that just sort of had to be worked through with time. Okay, community relationships. That was a big challenge. There was a lot of sort of interestingly, opposition from police. So police, for some of the mobile units, would sort of harass people who were using those services. Local Facebook groups were a big problem. I'm not sure if y'all are part of any of these groups, but that sort of are highly stigmatized towards people who use drugs and will basically be like, oh, they're, even say untrue things, right? About even if a program isn't giving away needles, we'll say, oh, they're giving away needles as a way to sort of bring community backlash against some of these mobile units. Local, as this person said, we weren't allowed to give out syringes anymore because of some news article that came out, even though that was not even a big part of their work. Next, COVID-19. Obviously, this is less of a thing now, but there was a week the entire team ended up with COVID, and so they had to close the mobile unit. As was alluded to earlier, consistency was absolutely crucial, going to the same place, the same time every week. And if there were, lapses in that, that made it very difficult to build relationships with the people who they were trying to serve. And finally, I had talked about federally funded study participation being a facilitator, but there were actually some people who described it as a barrier. So a lot of people found the attitude of folks from the like central study team condescending. So trying to teach us how to do overdose prevention and trying to teach us how to provide buprenorphine, and it was rather insulting. And the other thing that people said, which is absolutely true, is that there were tons of documentation requirements for the study. Like for those of you who've done, big research projects, you're constantly having to fill out forms and all this stuff, and it was a big burden on these agencies. Okay, future directions. There were a lot of ideas. So right now, for future directions, we are looking into controlled substance regulate registration to allow us to prescribe methadone. So a lot of the programs, all of the programs we talked to were prescribing buprenorphine and buprenorphine, but not methadone. But methadone was aspirational. Now there is a unit now in Worcester, Mass, that is offering dispensing methadone off of it, which is great. Which is great. But that's much less common than just buprenorphine and in some cases Vivitrol. People wanted to be able to do HIV and hepatitis C testing and treatment, which for some, would require more resources and funding and so forth. Um, and some people even talked about wanting to provide comprehensive medical care, primary care, all that stuff, because people who came in for buprenorphine also might have diabetes, high blood pressure, and they wanted to be able to treat that too. So funding, it was really interesting. So as I said, all of the programs basically talked about their concerns about financial sustainability, especially because their patient volumes were inconsistent. But one really creative and important idea, and some of you all may be working on units that are supported by this, working in settings that are supported by this, but is the opioid settlement funds. And so a lot of the organizations were really trying to see if they could get their mobile units supported by that money. And finally, a lot of these organizations were interested in furthering program evaluation. So I did just compile the data from year one about clinical appointments, and I think it would be a good idea to supplement that with some interviews or surveys from patients. But a lot of these agencies were community agencies that didn't have really a lot of funding and support for program evaluation, so that remains a challenge. So in conclusion, mobile MOUD programs expand access, medication access to marginalized groups. Um, Policy change. So I mentioned streamlined regulations. One thing I didn't mention was, you know, it's possible that a state Medicaid program could decide just to pay more for a visit done in a mobile unit. So improved reimbursement could actually improve promotion of these programs because we know for a fact, and I don't have the citation in here, but there's quantitative data now that shows that people experiencing homelessness and people of color are more likely to access mobile units than brick and mortar unit. So we actually are reaching folks who are harder to reach with mobile units. And so a Medicaid program could say we'll pay more for that. And that future opportunities include expanded medication. So I mentioned methadone. Now, injectable buprenorphine is interesting. I just got an email from a colleague, but basically the DEA is not interested in mobile units doing like Sublocade and Brixadi right now, but hopefully that will change. Harm reduction, so things like drug checking, in addition to fentanyl test strips and clinical services like I talked about. So those are some future directions. And that is the end of the prepared portion of the talk.
I have a quick question. Thank you so much for giving this talk. Have you guys been experiencing any issues in terms of areas that you're able to actually provide the street medicine? Because I'm from Philly and we have now been dealing with a ton of policy change where they're only letting us
Yeah,
provide care in very specific areas of the city. And I was just curious to see if you were having any issues with that.
absolutely. Yeah. That was a big issue that came up. I don't know why I didn't ended up on the slides, but that was a big issue that ended up on the um that came out of qualitative interviews that people, you know, would whether it was the city, whether it was a private business, the exact location of where they could offer services was always up for debate. It was a little bit of like a hot potato situation.
Mm.
People, if they found syringes in a park that was anywhere near where the mobile unit was, then there'd be city action and that the mobile unit couldn't be there. So that is a constant thing. So thank you for bringing that up. Now, interestingly enough, in Boston, the city is who approached us to do the mobile units. And so where we are there has been pretty fixed. Oh, one thing I'll say is that one thing we tried to do is we actually did a study of one of our mobile units, and we interviewed like patients, we interviewed providers. We wanted to interview business owners around where our mobile unit went because we wanted to get at like what their experiences was. Did they even know we were there? Did they feel like things were getting better, worse since we started our services? We canvassed like 60 businesses. Not a single one would talk to us. I can't always blame them. Like, you don't, if it's like some low-level employee, the extent to which they want to be like on the record, talking about stuff. But no one wanted to even talk to us. So I think there is a lot of room for research around programs like this, just to get a sense of what are these people that are afraid that things are going to totally deteriorate with mobile units around, what are they actually experiencing? So that's potentially a future study to be done.
Great.
Right. I see
Thank-
Eddie has his hand up.
Hey, Vic, what's up going on? I am a EM attending in New Jersey, actually. And I just got authorization that my program is going to get full funding. I actually got that yesterday, which is super cool.
Congrats.
Thank you. Few questions for you, and I'm probably going to send you an email too because I have a
Sure.
ton of questions. When you say that your van is very low barrier, are you working directly with the local pharmacy, like to do same day bupe like pickups?
So there's yes. So our you said you're from New Jersey? Okay. So one of the things that came out as a theme is a lot of these mobile units will have someone who can do insurance. So like we aggressively make sure people have insurance because all of the insurance plans in Massachusetts cover buprenorphine, and we have our own pharmacy at Healthcare for the Homeless, but we have relationships with all the pharmacies that are near our mobile units. All the mobile units that have been successful talked about basically a relationship with the pharmacy, but basically knowing the pharmacy that will either contact you for any problems or just solve problems on their own to be able to get people their buprenorphine. Now, there is a mobile unit in Chicago, Sarah Messmer runs, where they've figured out how to have, because there are these, I don't actually use these, but they have these buprenorphine like starter packs that I think are meant to be like emergency department distributed, but they actually do hold buprenorphine on the mobile unit and dispense it. But you would have to talk to Sarah about that. But there are some people like just that are trying to bypass the pharmacy barrier because that can be a barrier for sure.
Awesome. All right, thank you.
Mhm. All right, Emma.
Hi, thank you for the presentation. I am a second year family medicine resident in Houston, Texas. I'm actually, myself and one of my co-residents started a street medicine track, and we teamed up with our Healthcare for the Homeless Houston. And they have a mobile health unit that goes out once a week right now, but they got a grant expanding it to twice a week soon. Plus they have the physical clinic. So they do bupe and all that jazz in the clinic, writing scripts on the street. But of course, getting to the physical pharmacy who they have partnerships with has been a barrier. And we were toying around with the idea of long-acting injectables like Sublocade, and what does that look like on a mobile health unit? So I know you mentioned that the DEA is not interested in that at all. So I just want to know a little bit more about that, if you can expand on it.
Yeah,
Texas, I mean, in general, has horrible laws, lots of barriers, but I didn't realize that this is kind of an issue maybe everywhere.
I just was in this email thread, but there was a mobile unit somewhere in Massachusetts that basically just started doing Sublocade. And somehow the DEA found out and shut that down proactively, which is something that I feel like I don't hear about that much. So they really are not about that. Now, um, so I would say whoever your like medical directors or people are, there's always a state, and I'm blanking on the name, but there's like basically a state level agency that facilitates sort of controlled substances prescribing and distribution and all that stuff and all the rules around that. And so it may be worth trying to reach out. Moda, it's called the Moda, I think. But anyway, I'll look it up and send you the information. I can send you the information, but they would be the person to contact and to ask whether this is going to fly at all. Given that it looks like sounds like they are pretty against it. There's some situations where you can sort of do something and just ask for forgiveness rather than permission. But it might be worth in this situation to figure out something that's going to be that they'll be open to. Someone said, yeah, Sublocade has its own like world because the insurance situation is so weird around it. So there's like these buy and bill programs and all these different things. But I think that is less relevant here. I think it really is that DEA doesn't want this to be happening at all. So if there's a way to get around that.
Thank you.
Mhm. Eddie, did you have any more questions? You mentioned might have more than one.
I guess I'm also just wondering, so I don't want to ask too many to take over. Um, as we are now, I'm in the process of getting a van build. What does your van look like? I know you talked about the different aspects of what people actually wanted, but what actually is in your van built specifically for opiate use disorder and treatment?
Um, so yeah, it's a good. I do regret not having.
Do you have a bathroom? Do you actually have a bathroom on it?
Um, so we don't on the. This doesn't show the inside. Um, okay, this one picture. Okay, I'm just gonna share real quick.
Yeah.
The healthcare for the homeless van that I've been on, there are two. I've only been on one of them. Does not have a
Okay.
bathroom. But this one is I think this is the Brockton one. Yeah, this is the Brockton one. I think this one does have a bathroom because you can look at the size of it
Yeah.
and it's definitely bigger than ours in Boston. I think this one does have a bathroom. Are you in a situation where they will want you to get urine tests for patients? Or do
You
you that going to be part of your practice?
sure, it's kind of I'm not totally anticipating or expecting to have a bathroom on whatever rig I'm doing. It's really going to be like low stakes, but there are also the community partners that I'm working with are asking me to go. I'm trying to cover the fifth biggest city in New Jersey, and they've
Mhm.
already asked me to now cover the second biggest city, Jersey City in New Jersey, and that entire county. So I'm just kind of thinking like, how do you future-proof something? How do you get enough money off the start and try to utilize that money for good
Yeah.
without getting too big? So I'm kind of like weighing my options.
Yeah, a good person for you to talk to might be this woman, Allison Pinkover, who's in Brockton. Uh, it was a really she's really, really knowledgeable about all this, and she went all through this all with the Brockton van and trying to figure out what kind of, unit to buy and all the technical nitty-gritty. The future-proof idea, I think the bathroom is actually probably a good idea for that, but there's always pluses and minuses. A bigger unit, is going to probably, is going to be more expensive, more difficult to maneuver, and I assume there you have to somehow like deal with the waste and what so I don't even know how
As
you do that.
you said the bathroom thing, I was thinking like, am I going to be the one that has to drain this thing?
Yeah.
Like, so that is a good point. Yeah, if you could direct me, I can shoot you an email and to
Yeah.
maybe connect me with at least Allison, and I'll find Sarah on my own.
Yeah, Sarah Messmer's also great, and she's been writing a ton of papers about this stuff, so she'll also be knowledgeable.
Amazing.
I think Joshua.
Yes, thank you so much for coming and spending your evening with us. I'm a third year medical student at the University of Pittsburgh. I was wondering if there are limitations or restrictions to patients who are allowed to utilize services, whether they have to already be on a panel with Boston Healthcare for the Homeless,
Mhm.
or, I mean, we've seen back before encampments were swept and we had rounds. In Pittsburgh, we try to avoid sort of not territories per se, but if we know a group from a different organization is going to this area, then we would not go to that area as much. So I was wondering if, as people hear about this, can any member of the community come and access their treatment there, or do they have to be rough sleeping, experiencing unsheltered homelessness to qualify?
That's a great question. I know different places are different. Honest. It's always good practice to know who your neighbors are, who's providing services. You never want to be duplicating services, and sometimes you can be offering complementary services. So it's just important to know. Healthcare for the homeless, we will see anyone regardless of whether they have other providers or not. I know that isn't always the case. The example I'll give you is that I was talking to folks at the VA out in LA. They had a mobile unit for reaching people experiencing homelessness to do addiction treatment, but they had to discontinue it because as part of the VA, they were only allowed to see veterans. So they'd go out to homeless encampments and there would be veterans and non-veterans who would show up and they'd have to say no to the non-veterans. And basically they're like, this is not okay. We can't be rolling up to this encampment and telling most of the people we can't see them. So we have, but we've also been very intentional about it. We've negotiated, um, it is known that we take care of people who are primary care patients elsewhere. And so we've negotiated with the state Medicaid programs to be a part of what's called ACOs or accountable care organizations. It doesn't matter if our patients are at Mass General Hospital or the Brigham or Boston Medical Center. We can see them and we count toward the ACO, whatever, for either side. So yeah, so in a way we're a little bit unique. Like the VA can't do what we're doing, and I'm sure other organizations. I've heard about this too, that they have to see patients who are already impaneled or something. Fortunately, regulatory wise, we don't have to do that. We can see whoever we want. Amanda, you came off camera, or you came on camera. I'm not sure if you had another question. Okay, Sophie, I see your question in the chat. Thank you so much for sharing that. This is going on all across the country, certainly all across Massachusetts, especially in the smaller cities. Um, I haven't talked to Allison in a while. Um, I might see her later this month at a meeting. I could also email her, but we are hearing lots of really sad stories around, encampment sweeps, and just in general, very, you know, uh, challenging situations for people experiencing homelessness, and increasing regulations and like political hostility toward people who use drugs. I think tonight there's a meeting in Lowell, Massachusetts to try to either limit or end certain services. I just got an email saying they're trying to do this in Boston, so I don't know what's going on there. But so yes, I've heard that a lot of these agencies are having to scramble to keep up to where people are. So if an encampment is swept, like figuring out, where to go to find folks. In our experiences in Boston after sweeps, we just lose a lot of people. We don't know where they end up. And a lot of people who, for example, rely on us for HIV medications or PrEP, those visits go away and those patients are lost to follow up. So I imagine that Allison's probably experiencing something like that thanks, Eddie, where, they're doing their best to keep up with the patients that they can find. And then some patients are just being, lost through the cracks. Well, Divya, any other questions or anything else you want to talk to me about? You want me to talk about?
I think if that's all the questions, then we can end it there. But thank you so much for joining. It was an amazing talk. Um, and thank you everyone else for joining as well. I know it's a little late, but yes, and I will release the recording, I think in hopefully in the next week. Um, and yeah, thank you.
Okay. All right. Take care, y'all. Have a good night.